It's an honor to be here. I've come to pretty much every TM symposium since 2005 here and in Baltimore and other cities, and it's always a wonderful experience. I spend most of my time in the lab. I work on animal models for TM and Neuromyelitis Optica, and the rest of my time I spend treating patients with recurrent TM. So that's what I'm going to talk about today, is not the single episode of TM that happened a long time ago and you've been dealing with the consequences ever since. My passion and interest in the clinic is in dealing with those TMs that recur over and over and over again from a distinct immunological problem. And the disease I'm going to focus on that causes a lot of recurrent TM is called Neuromyelitis Optica spectrum disorder, or NMOSD. And it was named after, one of the first people to describe NMOSD was Dr. De Vick. He's the one who gets the credit because he published the biggest paper. Actually, only one patient was his, but he went back through the literature, dug up 16, 15 other patients, and described them back in the 1890s. And he recommended the name Neuromyelitis Optica because it's a disease that not only involves the spinal cord, but also the optic nerves, optica. But most people called it De Vick's disease for the next 100 years. And then the next important person in this process is Dean Wingerchuk, and Brian Weinschenker is sitting over here, who helped really redefine the disease. And they did it first in 1999 and then repeatedly over the years, and most recently just this year. And basically what Neuromyelitis Optica spectrum disorder is, it's an autoimmune disease that causes transverse myelitis over and over again, but it also involves other parts of the central nervous system. And on this graphic here, you can see I've set up a sort of spectrum where multiple sclerosis involves all parts of the central nervous system. Transverse myelitis at the bottom is, by definition, exclusive to the spine. And Neuromyelitis Optica kind of sits in between because it involves the spinal cord, but also the optic nerves and the part of the brain that connects them called the brain stem. It also involves some of the brain, but not quite as much as we think about with MS. Now, another way to think about Neuromyelitis Optica spectrum disorder is on these two axes. One is the recurrence rate, where Neuromyelitis Optica sits up here. Tends to be more relapses more often than patients with multiple sclerosis. And the other way to think about it is what we think about as humoral autoimmunity. And by that, I mean there are factors in the blood tests, blood abnormalities that are found in Neuromyelitis Optica. And again, it sits on this end of the spectrum. Humoral autoimmunity also means it tends to be responsive to plasma exchange, which is a good treatment for NMO. Now, over the years, the bubble of NMO has shifted down a little as we've recognized that patients with NMO don't always have this terrible relapsing rate. They can also have a milder course, and we recognize that now because we have a great blood test for that diagnosis. And so we know now that some patients with NMO have a lower recurrence rate and also have a little bit more involvement of the central nervous system than we previously thought, including some more brain areas, but that's a rarer presentation. So the definition now, as of 2015, is divided into two types of Neuromyelitis Optica. The type where you're antibody positive, this is a blood test. This blood test is widely available in the US and probably most parts of the world. And it looks for an antibody against a water channel called aquaporin 4. There are several ways to do this test. They have different sensitivities and specificities. But if you're positive in the context of a transverse myelitis or an optic neuritis, then you got the disease, Neuromyelitis Optica spectrum disorder, and you get referred to me. And what we know about this diagnosis is if you test positive, you're at a very, very high chance for relapsing. It's very likely that in the future, you're going to have another TM or another optic neuritis. That's why it's so important to get this blood test with your TM diagnosis. As I mentioned, if you're positive, you don't really need to have a lot of other criteria. You don't have to go through a list and say, okay, I have this, I have this, I have that, to get the diagnosis of Neuromyelitis Optica spectrum disorder. If you're positive and you've had optic neuritis or transverse myelitis or almost anything else, and it's not quite everything else, but with a little bit of judgment and a positive antibody test, you're in the family. Then the other way you can get the diagnosis is if you test negative for the antibody, then you need to have the checklist. You need to go through and really make sure that you have NMO. And that checklist is simplified here. That is, you need at least 2 lesions. It could be 1 lesion in the optic nerve, for example, and 1 in the spinal cord. That counts as 2 lesions. They have to be in separate locations. You can't just have 1 lesion in the spinal cord and another lesion right below it. That's too close together. We want to see it spread out across the nervous system. And it needs to be what we call MRI typical. I think I may have a couple MRIs here to show you. Takes a little bit of judgment. So if you test negative for the NMO antibody, you always want to bring your MRI discs to the expert you're going to see, who's going to make this judgment call, because it really involves going through MRIs on a regular basis and getting a sense for what this looks like. That's what we mean by MRI typical. And then you also have to rely on the judgment of your neurologist to rule out other diseases like multiple sclerosis. That's our most common competitor. And so we really want to make sure you don't have MS. And the distinction is important, because if you do have MS, there are some 8 FDA-approved drugs that you can go on. And if you don't have MS, if you have NMO, you want to, by and large, avoid those FDA-approved drugs for MS because they could make your NMO worse. So it is important to really work up this diagnosis if you're negative for the antibody. So NMO is kind of a rare disease. The thought is it makes up about 1 or 2 people out of every 100,000 in the United States. And if you extrapolate that out, if you calculate the total number of NMO patients as a percentage of the demyelinating disease, it's about 1.5%, and the other 98 is pretty much MS. So in Caucasian countries like ours, I shouldn't say Caucasian country like ours, I should say Caucasian predominant countries like ours. And in Europe, the percentage is about the same. But if you look around the world, in primarily non-Caucasian countries in the Caribbean, South America, and India, Japan, I think Singapore is around here, it makes up a much higher percentage of demyelinating disease. My colleagues in Japan will say, for example, if you come in with a bad optic neuritis to the clinic, you pretty much have a 50-50 chance of having NMO, or what they call traditional or Western MS, which is what we see here. So it's much more common in these non-Caucasian countries as a percentage of their demyelinating disease. We profiled our patient population in the United States. This was a group among us at Hopkins and the Mayo Clinic and UT Southwestern here. And we found that the average age of onset is somewhere in the early 40s. Our average patient now is in their late 40s, but at onset they usually get diagnosed sometime in their early 40s. That's when the disease usually starts. And that's really different from MS. In MS, the average is sometime in the late 20s, but it's much more similar to rheumatologic diseases like lupus, rheumatoid arthritis, where the diagnosis, and Sjogren's syndrome especially, where the diagnosis is in the 40s. And so this NMO fits in that spectrum better than in the MS spectrum in that regard. But you can see we do have quite a range. We had a few pediatric NMO specialists here yesterday. I don't know if they're in the audience with us, but they see lots of kids with NMO as well. And we also have a unique population of elderly patients who have NMO. My oldest is 91 now, maybe 90 years old. And there was even, there are 2 recent publications on NMO presenting in the elderly. So you think you go through your whole life, healthy or a little bit of hypertension, and then you turn 85 and then you get your first TM. That's pretty crazy, and it's part of this NMO spectrum disorder. So we've seen a few cases like that now. It's not unheard of. I also want to point out the female to male ratio is a little bit higher in NMO than in MS. Most autoimmune diseases, women are more predisposed than men. That's generally true. But in NMO, it's higher than MS even. And so in my clinic, it's pretty rare when I get a man who comes in with a diagnosis of NMO. I say, you're maybe 1 in 10 or 2 in 10. So that's pretty rare. But they, it happens, and it's not entirely clear why. It's not. We're just beginning these studies of looking at the effects of hormones on the disease, both in women and in men. And so that's ongoing, but we don't really understand why it's so predominant in women. I mentioned the prevalence in non-Caucasian countries. Within the US, you can see here that African Americans make up a higher percentage within the NMO population compared to the general population. So African Americans make up 12 or 13% of the American population, but they're threefold overrepresented in the NMO population. And so that goes again to that predisposition among non-Caucasians. I'll point out also that there may be a higher rate of NMO as a percentage of demyelinating disease in other non-Caucasians as well. So NMO presents with TM most of the time. That's the first event. And so you may be diagnosed with TM before you're diagnosed with NMO. That is not at all unusual. I've seen that all the time. And if that happens, you're probably going to land in the care of a neurologist, which is good, because neurologists now are being trained for every TM case to get an NMO antibody. Maybe not every neurologist, but most neurologists know now, if a patient comes in with transverse myelitis, get the NMO antibody, because it's highly predictive of a relapse. So we're good about that now. And about half of cases present with TM. About a third will start off with optic neuritis. And sometimes you end up in the hands of a neurologist, but oftentimes you'll see an ophthalmologist first. And they may not be as aware as we are of the NMO antibody test. And so sometimes what I'll see in my clinic is, well, I had optic neuritis, and then I had optic neuritis again, and then I finally had transverse myelitis, and then got the NMO antibody test. So that's pretty common as well. One of the hallmarks of NMO is this idea that the optic neuritis and the transverse myelitis happen at the same time. That was kind of one of the original descriptions. It's how we teach it in med school sometimes, is that the NMO patient will present with optic neuritis and transverse myelitis simultaneously. And it turns out it still does happen. It's just not as prevalent as we thought, but 10% of cases still present with both within a month. And I can recall a few cases of transverse myelitis occurring in the hospital. We start treatment, and within a couple of days, the patient will say, you know what, I also can't see out of my eye. And we get the brain MRI, and we see, oh, they in fact also have been developing an optic neuritis at the same time. And then, as I mentioned, now that we recognize that we have a great blood test for NMO, we recognize a broader spectrum of disease. They can involve different parts of the brain in some weird and unusual cases, but now we recognize them to be NMO, and they don't involve either the spinal cord or the optic nerve, but we're learning more about them. Fortunately, they're rarer. And I added this graph here to emphasize the point of age on the type of presentation that you'll have. Either optic neuritis in blue or transverse myelitis in red. And age is represented here on the x-axis, so the older you are, the more likely you are for your next relapse to be transverse myelitis, versus the younger kids whose next relapse is most likely to be optic neuritis. In fact, we had a group here in the mid-teens, I guess about 15 years of age, where almost all relapses were optic neuritis. This is a combination of our patients with Japanese patients, so it's not race-specific or country-specific. It seems to be age-specific, and we don't exactly understand why this occurs. Okay, here's an MRI I promised to show you, which is in large part, how we make the diagnosis. Dr. Greenberg mentioned the fact that NMO tends to have long lesions. Well, what does a long lesion look like? So here we have an MRI where this is the back of the patient, this is the front of the patient. You can see their chin right here, and this is the tongue. And the brain is up here. The spinal cord extends down here. It's this gray structure. It gets lost here, but within this gray part of the spinal cord, there's a long white line. That's the lesion that we're counting the length of. That's called the T2 weighted image. And the length of this lesion can predict whether you're more likely to have Neuromyelitis Optica or something else. And so that's what we count. And you can count the bones here. Here are the bones, the vertebrae. So for example, I think that this lesion starts here, 1, 2, 3, maybe a fourth. So that's a 4-segment lesion. So that's pretty long. And that's more consistent with Neuromyelitis Optica than what we used to call idiopathic transverse myelitis. The other MRI I want to point out here is called the T1 post-contrast. And it's the same view. The tongue is cut off a little bit, but you can still see the spinal cord here in gray. And the abnormality is this small white part right there. This is the same lesion at the same time, but this sequence provides us with a view of an active process. So I get a lot of patients who call me and they say, I'm having these symptoms. Am I having a relapse? And one of the first things I get is an MRI because it provides a glimpse into the spinal cord whereby any active process can be highlighted and easy for me to see. And then I can say, okay, you need this type of treatment versus a patient who doesn't have a relapse that may just need symptomatic care for something like pain or spasms, which I want to treat, but it would be very different from treating a patient that has this. So MRI is very useful, not just in making the diagnosis, but in figuring out if you're having a relapse. Most of my patients don't get a lot of brain MRIs. They get a lot of spine MRIs, and they get a lot of optic nerve MRIs, or what we call orbital MRIs. But we largely have been leaving the brain alone because NMO was not really a disease of the brain. But when we look at the brain, we do find a few abnormalities. Turns out only 40% have what we call a totally normal brain MRI without a single lesion. A majority have something, a brain MRI that does have either some spots that don't have any particular pattern or a pattern that looks very much like multiple sclerosis, making it even more difficult to make the diagnosis. We're just beginning to learn about the broader spectrum of NMO that involves the brain. Our research colleagues in the radiology department are going to be very important in this regard. Now, the type of blood test you get can be different depending on where you get tested. I think in the US there are only 2 options. There's the option at Quest and LabCorp, and they use what's called an ELISA test. It gives you a number. And that number goes anywhere between 0 and 160. Now, LabCorp recently expanded that number, and they said, we're not going to stop at 160. We're going to tell you what it is into the thousands. But they give you a number. And anything greater than 5 is considered positive. There's some judgment call in patients who have numbers like 3, 4, 5, 6, 7, where it's not clearly in the positive range. We may need to think about your case a little bit more. But clearly, if you're in the 50, 75, 100, 150, that's a very positive from our point of view. The Mayo Clinic has a somewhat different assay that may be even more sensitive. So sometimes you'll get a negative test from Quest or LabCorp, and your doctor will say, you know what, I really think you have NMO. I'm going to send your test to the Mayo Clinic. Well, don't think he's wasting your time. It's testing for this antibody, this NMO IgG blood test, but testing it for it in a different way. And it may be better depending on the assay, but it's always good to check it. If you're positive by the ELISA assay, you don't necessarily need the Mayo assay. If you're positive by the Mayo assay, you definitely don't need any other assay. So you only need one positive test. Again, the clinical context matters. We do get some patients referred to our clinic who have a positive test after they had a trauma or fall or something like that, where the clinical context is not transverse myelitis, it's something else, and they just happen to order the test, they may be positive, and the context does matter in those cases. Okay, so what are the most common symptoms in NMO? Well, the bottom half here is bottom part here is very similar to what TM patients experience, including weakness up here. So weakness, bowel and bladder dysfunction, pain, depression, cognition problems, and fatigue. It's like preaching to the preacher here, right? You guys know what those symptoms are. It's the exact same symptoms. They may be more severe, they may be less severe, there may be more healing afterwards, there may be less. There's no, we can't predict in an NMO patient who's going to do well and who's maybe not going to do so well. But in addition to these TM symptoms, we also have visual disturbances. Our patients can be blinded sometimes. If the optic neuritis is particularly severe, they can have color vision problems, pain behind the eye, so a few other symptoms that maybe TM patients don't get as much. One thing I want to emphasize about TM and NMO is that a lot of the symptoms, especially late, so 6 months out from your event, a lot of the symptoms that you're still experiencing are not due to the immune system anymore. The immune system caused damage, whether it's in the optic nerve or it's in the spinal cord. The damage was done, and now you're going to have symptoms from that damage. You're going to have a period of healing and hopefully a lot of healing, but sometimes it's not complete. And the rule in neurology is that the symptoms will fluctuate as you heal. And for many years beyond that, you may have spasms and pain and other symptoms that are just due to the damage. And so if you have TM, if your doctor says you don't have NMO, you just have TM, and 6 months down the line you have pain and spasms, it doesn't necessarily mean that you're having a recurrence. It doesn't necessarily mean you have NMO. It could just be symptoms from your previous attack. And the point this really highlights the point of this slide, which is that the most common symptom in my patient population of NMO patients is pain. About 80% of my patients have pain from their attacks. And again, the pain is not usually right at the beginning. Usually at the beginning of an attack, there's weakness, there's numbness, there may be vision loss, but then as they heal, the pain really starts to come on, and it can come on for the next 2, 3, 4, 5 months. It gets worse and worse and worse, and they think they're doing worse even while they're actually healing. And there's two different types of pain. There's one that we call neuropathic pain and one that we call spastic pain. Neuropathic pain is more related to nerve damage, and spastic pain is more related to spinal cord stimulation of muscle. And so you can get these muscle spasms, and you can get this burning, tingling pain, and they're treated a little bit differently. Sometimes they're treated, there are drugs that treat both, and sometimes there are drugs that treat just one or the other. So we try to sort these out. And this is common not just in NMO, obviously, but in patients with TM. So finally, I just want to get to the idea of, is it a relapse? This was the whole point of the talk, is TM patients have symptoms ongoing for sometimes years, sometimes for the rest of their lives. So the big question they ask me is this a relapse of my TM? And the answer is that it depends. There are many clues that can predict whether it's a new attack. For example, if let's say your previous TM only affected your right leg, and then you wake up one morning and your left leg doesn't move, well, that's pretty typical of a relapse. Whereas if 6 months ago you lost complete sensation in your left leg and you wake up and now you kind of lost sensation in your left leg again, that may not be a relapse. It may be due to something else. Well, what else can do that? The other things that can do that are fever and infection. Sometimes patients will have an infection like a urinary tract infection that they don't even feel. Maybe they don't have as much bladder sensation, so they have an infection brewing and it's causing symptoms in their leg, which is crazy to a patient. Why would a urinary tract infection cause leg numbness again? But it can happen. Even ambient temperature. I have a lot of patients who in the summertime are very heat sensitive and their symptoms come back. Exercise increases body temperature, so does stress. Even medication changes that can change their pH in your blood or any of your metabolic profile can also impact on those old symptoms. Usually, though, what I hear is that the symptoms will fluctuate. They may get better. Maybe we'll get better with antibiotics. Maybe we'll get better with rest and cooling off. And that's a good sign that this was not a true relapse, but rather just a recurrence of symptoms from old damage. And again, if that's what's happening, this is not inflammatory driven. The immune system is not acting up here. And there's no point in getting steroids or plasma exchange because those treatments impact the immune system, and the immune system is not involved in these symptoms. So I'll leave that. Actually, this slide is a little bit outdated. I have 3 kids now. The third one doesn't make it on the slides nowadays, but I have. She's now 6, she's 4, and the boy is 2. So I'll take any questions. I think we have time for a few.